Good evening. I'm Marion Dry, Chair of Class Act HR 73, and it's my great honor to welcome you to this evening's forum, Reproductive Justice: Is Being Pregnant a Crime? With this forum, Class Act HR 73 launches our 2025-2026 forum series, Democracy at 250. This series will run through May 2026 and will include forums about the changing role of the U.S. military, the role of culture in our changing society, and the history and challenge to environmental protection, and finally, digital media and freedom of the press. Tonight's forum is a joint production of Class Act HR 73 and our bridge partner, Justice Aid. And we're delighted to be doing this with them this evening. I'd now like to introduce our moderator and my friend. Dr. Vivian Lewis, class of 73, is Professor Emerita of Obstetrics and Gynecology at the University of Rochester Medical Center and a board member of Class Act HR 73. Her perspective as a professional comes from experience with delivery of healthcare, overseeing clinical trials in women's health, and leadership roles in several national organizations, including the National Institute of Child Health and Human Development, the National Medical Association, and the American College of Obstetrician Gynecologists. She is the president of Columbia University's College of Physicians and Surgeons Alumni Association. Vivian, welcome.
Thank you. It's a pleasure to be here and to moderate this distinguished panel. I'm going to introduce them briefly and then we'll get started. Just as a reminder, again, when you have questions, please put them in the Q&A rather than the chat. We can get to them after the panel discusses some questions that we've already prepared. So to start, I'd like to introduce our panel. Dr. Jamila Parrott, first up, is a fellowship-trained, board-certified obstetrician gynecologist and president and CEO of the Physicians for Reproductive Health. This is a physician-led organization that mobilizes the medical community, educates and organizes providers, and uses medicine and science to advance access to reproductive health care for all people. Welcome, Jamila. Pleasure to have you here. Karen Thompson. Attorney Thompson is the Director of Litigation at Pregnancy Justice, and she leads a team of attorneys who advocate for women and all those pregnancy-able individuals who are prosecuted because of their pregnancies or pregnancy outcomes, whether that be a birth, a miscarriage, stillbirth, or an abortion. Welcome, Attorney Thompson. Finally, we have Dr. Jenna Tosh. She is the president and CEO of Planned Parenthood's California Central Coast. She holds a doctorate in public affairs from the University of Central Florida. Since taking the helm at Planned Parenthood, Dr. Tosh has led the implementation of evidence-based programs, the expansion of sexually transmitted infection services, and Planned Parenthood of Central Coast California's expansion into gender-affirming care. Quite a tall order. So you can see that our panel is quite diverse and well-equipped to delve into this subject tonight. I'm going to have a couple of rounds of questions. In the first round, I'll invite each panelist to explain the term pregnancy criminalization. It's not exactly in the common parlance, and briefly describe the impact on patients, medical providers, and communities. First, let's hear from Karen. Karen, explain, what does this mean, pregnancy criminalization? And please give us a few examples. As well, tell us what pregnancy justice does and why it is important to have an agency devoted to litigation and legal services.
Absolutely. And thanks so much for having me. It's really a pleasure to be here tonight. Pregnancy criminalization is actually quite simple. It is the criminalization of pregnancy, where folks are punished or penalized for actions that are interpreted as harmful to their own pregnancies. That means they're charged, arrested for crimes, including the enforcement of laws that punish actions during pregnancy that would otherwise not be criminal or punishable. And so to kind of put that into context, what that looks like, for example, we had a client who actually fell down the stairs in 2010 and she lost her pregnancy. And while she was being treated at the hospital, she confessed to a nurse that she was, a little bit ambivalent and she wasn't sure if she'd wanted the baby. That nurse reported her to the police and she was accused of feticide before the charges were eventually dropped. Another case that kind of speaks to this issue is Bebe Shui, and this is another older case. This happened in 2006, but she was left by her boyfriend when she was 33 weeks pregnant and was absolutely despondent about that news. And she swallowed rat poison and tried to commit suicide. And the next day, the baby was delivered prematurely. And even though Miss Shui survived the suicide attempt, the baby unfortunately died a few days later. And she was subsequently also charged with attempted feticide and murder and faced 45 to 65 years in prison because she was clearly in distress and had tried to end her own life, right? And then the third kind of example would involve somebody who was pregnant and their baby unfortunately had an umbilical cord wrapped around their neck and was never able to take a breath. She gave birth to this stillborn child when she was between 15 and 17 weeks pregnant. And she was drug tested without her consent or knowledge, and there was cocaine found in her system. And rather than being given the health care she needed, just as health care, she was charged with murder for testing positive for cocaine, even though it was very clear from what had happened that the baby had the baby's demise was attributable to this cord wrapped around the neck, right? So all of these behaviors, all of these things that really have nothing to do, obviously, with murder are turned into criminal acts. And so there's a carceral response to what is usually a healthcare issue. And that is kind of the core of pregnancy criminalization. And so as pregnancy justice is a legal not-for-profit, focuses on these cases, and we work with allies, we work with public defenders, we work with lawyers all over the country on these cases. We hope to provide three main pots of assistance: direct litigation, strategic litigation, impact litigation. But we also want to equip the field with information. So we do quite a bit of research and provide data to individuals about these cases, about what we're seeing. And we also have a policy wing. And our work is to make sure that there are laws that do not justify or move forward things that allow pregnancy criminalization. And the main one is fetal personhood, and this idea that a fetus has constitutional rights, the same as everybody on this call. Because that idea that a fetus's rights might trump the rights of a pregnant person, that's kind of the core of what drives pregnancy criminalization. It's the engine of pregnancy criminalization. So we use all of the information that we have, all of the work that our lawyers can do to fight both pregnancy criminalization and fetal personhood as the thing that makes it happen.
Those cases are certainly heart-wrenching, and for sure, I'm not an attorney, but I can see how people in that kind of situation obviously need legal assistance. And also, I believe it would go to the case law and provide assistance to somebody down the line. So thank you for all that you do and for telling us about it. Next, I'd like to hear from Jenna Tosh. Jenna, tell us about what Planned Parenthood does. Many people think that Planned Parenthood simply provides abortion. I know that's not the case. Please inform our audience. And tell us also about the impact of the defunding of Planned Parenthood on patients, including those who are not pregnant.
So it's great to be with you all tonight. So Planned Parenthood, as many folks know, is a nonprofit healthcare provider. We have been around for over 100 years. And across the country, there are local Planned Parenthood affiliates. I am representing Planned Parenthood California Central Coast. We are an affiliate that serves 3 counties here on the California Central Coast. And, essentially, Planned Parenthood is an organization that provides a wide range of healthcare services. Planned Parenthood mostly provides STI testing and treatment, all FDA approved forms of birth control, breast and cervical cancer screenings. My affiliate provides behavioral health care, well person care. You mentioned gender affirming care for trans and non binary folks. We provide vasectomies, menopause care. And then there are some affiliates that also have prenatal care programs, primary care programs. At my affiliate, we are launching a postpartum home visitation program. So there's sort of a variety of different services that cause people in the community to come in contact with Planned Parenthood as a healthcare provider. We also provide abortion where it's legal, which, 3 years since Dobbs is no longer everywhere. There are 21 states that have enacted abortion bans, but where abortion is still legal, Planned Parenthood is still a provider. And, Planned Parenthood is here for everyone, but the vast majority of our patients are women of reproductive age, are women between the ages of about 18 and 30. And Planned Parenthood really is part of the public health safety net, right? We serve a large Medicaid population. We never turn patients away due to lack of ability to pay. Here in California, across the state, there are 109 Planned Parenthood health centers. And collectively, we provide care to almost 1 million patients every year here in California. And 80% of our patients rely on Medicaid to access healthcare at Planned Parenthood. I will say every Planned Parenthood is impacted differently by the defund, but here in California, the impact is enormous because what it means is that Planned Parenthood cannot be reimbursed with federal dollars to see patients in the Medicaid program. And so, the impact here has been huge. On July 4th, the president signed HR 1, was the so-called Big Beautiful Bill Act, which contained a lot of really harmful things, and also included this defund Planned Parenthood provision. And for about the first 2 months, there was an injunction from a district court that blocked the implementation of the defund. But we lost that injunction 2 weeks ago. So what that means is that every Planned Parenthood across the country has not been able to bill Medicaid. And so there's really a patchwork of different responses happening, plus primarily of state legislatures to step in and fill the gap and ensure that patients can still be seen. And that's our goal of ours here in California is to at least temporarily replace federal dollars with state funds so that patients aren't turned away. But, ultimately, what does it mean if Planned Parenthood is no longer able to serve this large Medicaid population? It means that health outcomes will be worse. It means that sexually transmitted infections will rise. It means there will be more undetected cancers, more unintended pregnancies. Ultimately, it will make pregnancy more dangerous. And all of this has a disproportionate impact on people who are Black, people who are Latinx, people who are Indigenous, people with low incomes, people who live in rural communities, people who already face the largest barriers to accessing healthcare as it is. And one other thing that I'll note, because I think a lot of folks don't expect this, is that the defund is actually disproportionately impacting states where abortion is still legal, right? So I think a lot of my donors and supporters say, well, we're in California, right? Surely it'll be okay. Or, I'll hear from colleagues, we're in New York, it will be okay. And the reality is that states like California and New York are the ones that have, due to robust investment in reproductive health, actually have the most to lose.
Thank you. It's kind of unbelievable. You describe such a wide range of services, a lot of which have nothing to do with pregnancy or abortion, and everybody suffers, and ultimately the whole population. I'm going to ask Dr. Parrott now to weigh in. Can you tell us what the impact of pregnancy criminalization, let's get back to that, is on medical providers, something we haven't touched on yet, and explain why this is an issue for everyone?
Thanks so much for that question and thanks for having me. I think, one of the things that I want to start with is really some context as we think about the impact on healthcare providers and all of us writ large. And the thing that's important to understand is that the medical system has always had deep ties to the carceral system. And so you have to understand that as a starting point. We've seen this as far back as the criminalization of Black midwives in the South and the care that they provide that was led by doctors that were in the American Medical Association, the American College of OBGYNs, the campaign to discredit and to criminalize those providers. The criminalization of abortion care began with a desire to express control over the reproductive process by physicians who were at that time all men and all white. And so the ties to the carceral system is really part of the foundation of medicine. So when we look at criminalization showing up today, then it is no wonder that we continue to see those impacts simply in different forms. When we think about what it looks like for healthcare providers, the organization that I run, Physicians for Reproductive Health, we are doctors. And so we recognize that as physicians, we hold a lot of power and privilege. And as we began thinking about the impact that this was having on the patients that we care for, the communities that we served, it was an easy choice for us to step into this fight up full force and to acknowledge and admit that the vast majority of people who are criminalized because they were seeking healthcare services. So it is their healthcare provider, it's the doctor, it's the nurse, it's the social worker that is then putting them within the snares of law enforcement. And that happens for a lot of different reasons. Some of it is simply confusion, right? Confusion about mandatory reporting. Is this legal? Is it not legal? Am I supposed to call someone? Sometimes it is malintent, right? A desire to punish. One of the things that Karen talked about was punish and penalize. And so that's important to understand again as part of the historical legacy of racism within the medical system, the desire to punish, to penalize, and to control. And so sometimes those reports are malicious and it is a desire to punish the individual. A lot of times it's simply ignorance. But the outcome, regardless of what the intent was, is the same. It causes harm for the folks that we care for. It does not keep them safe. So it causes chaos, right, for healthcare providers, unsure of what to do, a lot of fear. Well, is it better for me just to report so I don't get in trouble? And maybe I'll just go ahead and make a call. And if it's nothing, the belief that this is innocuous, right? That these calls are innocuous and harmless if nothing comes of it. And that is simply not the case. So the work that we do is to educate providers to say the investigation itself is the punishment, regardless of what comes from it. And it is part of our moral and ethical obligation not to call the police on our patients. Full stop. So we talked about the fear, we talked about the chaos. The other thing that we have to acknowledge in terms of the impact on healthcare providers is that it really, when we look at this rising role of criminalization for people for their pregnancy outcomes, it is simply a reinforcement of the dominant narratives and long-held beliefs about the need to control the health and well-being of the pregnant person's body, right? So we're talking about patriarchy undergirding medicine. As a doctor, I must know what's right for you. You must need to come through me to be able to take good care of yourself, right? And so the reason why I lift all of those things up is because if it is truly our desire to interrupt these acts of criminalization, we have to begin with acknowledging where we started, how we got there, so that we can begin making the repair. Quickly, why is this an issue for all of us? Is because criminalization of people who are poor, people of color, young people, undocumented people, immigrants, those who don't speak English as a primary language, all of these ways that folks are criminalized is simply the canary in the coal mine. And we have to understand that if we allow the criminalization of any community, the likelihood that it will come to our front door is really high, right? This belief, this understanding in reality that our liberation is bound. And so you can't be free if I'm not. I can't be free if you're not. And so when we're talking about why it's important to defend folks who are at greatest risk, it is because it is simply a matter of time before we see this unfold for all of us. And I think the Roe decision is a really good example of what that looks like, right? Think back to the Roe being decided in 1973. Not 2 years later, we had the Hyde Amendment, where there was this universal agreement that it is okay to limit access to abortion care for those who are reliant on the government for their insurance. Medicaid, military, Peace Corps, NGOs that are international, right? All of those, we said it's okay for them not to have equal coverage. And so that's what that looked like. And we said, okay, that's all right. But we still had this idea that abortion in and of itself would be ultimately protected by Roe. And we can see today that that is not the case. From the passage of Roe, followed by Hyde till present day, there's been a constant chipping away of access to abortion care, a chipping away of autonomy and agency for those who are trying to exercise their reproductive freedom. But it began with a group of folks who had lower social capital, who we allowed to be disenfranchised and separated from care. And so that is why, if for no other reason, we should all care about this issue.
That was so well put. You're right. It comes full circle. It does affect us all. I can remember colleagues who've had death threats for performing abortion and or even just for advocating for patients who need access to these services. And there are instances of physicians who've been killed for that very reason. I know Planned Parenthood is no stranger to these kinds of threats as well. Some of those have been quite public. So thank you all for illuminating what we mean by criminalization of pregnancy and how it impacts so many of us. It impacts all of society, even those of us who are beyond reproductive age. And you raised a good point, Jamila, that even before Roe versus Wade, access to reproductive care has been chipped away. For one thing, in a more recent past, at the state level, many providers, well-intended providers, we'll just stick with those, are confused. What am I supposed to do? Do I need to report? Do I need to not report? Can I give care legally? They get on the phone with the lawyers, and meanwhile the patient's bleeding out. It's not a good situation. So providers and patients are often in a reactive and even a crisis mode. You sort of alluded to the fact that we can think about a systems approach to affect change. I'd like to hear from all of the panelists of what they think that could look like, how we might collaborate among organizations, and what sorts of grassroots efforts we might take. So Jamila, since you took us in this direction, I'm going to ask you to answer that one first.
Sure. So I think it's such an important frame to adopt when we're looking at solutions, right? It doesn't do us any good to point to one or two bad actors, so-called bad actors, who are carrying out the criminalization of people when they're seeking care, because it requires all of us to allow this system to work, right? We are all complicit. And upholding what we are seeing play out today in lots of ways, right? And so the benefit of a systems-based approach is really to zoom out, to think about what are the levers that we can pull. So whether we're talking about policy and really thinking about who those policies benefit most, and what is the likelihood that all of us would get the benefit. For me, when I think about systems-based approaches and solutions in general, I always think about them from a Black feminist organizing perspective, right? The organizing from the margins. So if you create systems of care that benefit those that are at the margins, who are least likely to get this care, then everyone else on the inside will benefit. And that's the way we have to think about systems. We have to think about who is holding the power, who is most impacted, and make sure that when we're thinking about solutions, those who are most impacted are the ones that are driving those solutions. So it's not me sitting around in my office, wherever, writing a list of ideas about policy changes for what will make a difference in Mississippi when I live in New York. Right? I don't live in New York, but if I lived in New York, right, writing about it in Mississippi. And so that's not what this is about. This means actually for healthcare providers like me, it means being in community and really working alongside those folks that are directly impacted as we seek solutions to care. When we think about what this looks like, really concrete things in the medical realm, it means accountability for healthcare systems and healthcare providers. A lot of times, this turning over of information that results in criminalization is a HIPAA violation. And so we remind our colleagues that by turning over medical records and charts full scale to law enforcement simply at their request is a violation of HIPAA. And so being really clear about what the law is and how you can uphold it, also understanding that you have an opportunity to refuse to collude. I think that there is a belief that simply because law enforcement asks that you have to say yes. And I can tell you from experience, that's simply not the case. And so, really understanding what your role is as a person of power within that system, and then what kind of systems-based changes you can make where you are. So it's hospital policies, for example, these test and report policies, unconsented drug testing. If you're a healthcare provider that is at a facility that is engaging in these practices, you have an opportunity to disrupt that system and to be very clear about, one, not being participatory or complicit in these behaviors, and two, working to change those internal policies. This was not always the rule. Someone made this so. Someone decided that when you're pregnant and you show up to labor and delivery and we're suspicious of you, we're going to send a drug test. And so those policies sometimes go as far as to say those who receive Medicaid are drug tested universally, right? Or some people who live in certain communities in certain zip codes, right? And so those policies and practices were put in place by someone or a group of someone's and ultimately can be changed by someone and groups of someone's, and that someone just happens to be you.
Jenna, would you like to take a stab at this? Planned Parenthood is certainly in community with such a diverse group of people. I imagine you have a lot of immigrants, you have a lot of rural patients. Tell us a little bit about how you would think about this question.
Yeah, I mean, I've just been nodding along with Dr. Parrott. I think from my perspective, and I think it's important for everyone to kind of see it this way, is one of the outcomes of losing Roe has been, there is now this very confusing patchwork of laws and providers and access across the country. And it's not only confusing for providers, it's extremely confusing for patients. It's confusing for activists, it's confusing for donors, and it's confusing for lawmakers even, right? And so I think one of the most powerful things that any of us can do is find the people in your community who are doing the work on the ground to support patients, to advocate for systems-based solutions that are available in your communities, is to find those organizations and stay involved long term. And so, I think one of the things that people can do, number one, is find out and educate yourself about what are the laws in your state today. How are people being impacted by that? I would encourage folks to figure out, if you don't already know, who is your local Planned Parenthood affiliate, and how are they being impacted by the defund? What's happening to patients in your communities? Where are they going, and what are the actions that you can take? Because one of the realities is that because the situations are so different across the state or across the country, is every state has a different solution. And I also really want to lift up what Dr. Parrott said about not trying to solution, because in every single community across the country, there are people on the ground who are doing this work and who need your support, right? And so one of the things that we saw in the early days after Roe were a lot of people saying, I want to donate my house for patients who are traveling for abortion care. I want to, do all these things. And we were like, great. There are abortion funds, in communities all across the country, and they are experts in finding paths to care for patients who need it. And we encourage you, right? Don't call us, call them and provide resources and time, because there are advocates on the ground who know and who are very close to the need, and who have already done the work of building trust with the people who really are who are the most vulnerable in this environment.
Trust is critical, really.
Mm-hmm.
So Karen, could you reflect on this question, please? I mean, you have a national reach and you're certainly well informed about policy. What do you think we can do? How can we collaborate? I mean, even as I try to immerse myself in this topic, I'm shocked to see lots of states have passed constitutional amendments, and yet it's contradicted by some other policy. And so where does that leave patients? Where does that leave providers? So sorry to make that a mishmash, but give us your take on all this.
Yeah, I mean, first of all, I want to say I wish nodding was like a cardio activity, because I feel like listening to Dr. Parrott and Ms. Tosh, like the nodding in agreement is very real. I think one thing that has to be distinguished is that legal definitions and legal questions are not heard in the same way in courtrooms as medical questions, even though we're talking about the same thing. And so, one of the things that I think is particularly difficult as we look at these cases is that if we're talking about, say, viability, that is a framework created by the courts that doesn't map very well or directly onto a medical understanding of what viability is, because OBGYNs are talking about viability as in how would we treat this fetus if it was born into the world, whereas the courts are saying at this moment of viability, we believe that the state then has an interest in your body that supersedes the fetus's interest, and the state's interest in that fetus supersede the rights of the pregnant person, right? So those are two very different ways to talk about something. So that is kind of an automatic issue. But when it comes to what we're doing with the law and how we're trying to get into these cases, the first thing is we have an intake line. So people reach out to us when they need help in their cases. And there's a wide range of places where we have found ourselves having to enter. Dr. Parrott mentioned this kind of unconsensual drug testing that happens, but there's other issues that are implicated with that go along with criminal defense issues that we see across the legal system, right? So there's a question about junk science or bad forensic science and bad testing. There are people who might have been on their way to give birth, who had a poppy seed bagel or a salad with poppy seed dressing. They get to the hospital, they're tested without their consent, and that test comes back positive for opiates. The next thing they know, their child is taken from them at birth, and Child Protective Services are called on them either at the hospital or directly after release, right? So there's a way in which, again, to echo Dr. Parrott, this kind of thing never stays still. People might think, well, I'm not a drug user. That would never impact me. But the fact is, you don't know if it will. We recently, just this week, had a discussion about Tylenol not being something that pregnant people should be taking. And the fact of the matter is, medically speaking, if someone is pregnant and they have an incredibly high fever, that can lead to some very specific difficulties and harms for the fetus, right? This is not just something to play around with. Tylenol treats a fever, which could actually make a pregnancy safer. But now we are in a territory where Tylenol is being made suspect, which means that if people are thinking of it as a dangerous drug, and you live in a place where any drug use can be during pregnancy can be determined to be a criminal act, then we are getting to the place where providers who know that someone has taken Tylenol, or anyone who wants to kind of snitch on that person, might make them susceptible to criminal penalties, right? So I think that when we talk about these issues, we need to be very, very mindful of that slippery slope, of that kind of ripple in the water effect that all of these questions that we've been talking about hold for the purposes of pregnancy criminalization. They will impact a lot more people than we think they will. It's not going to be those people over there. It's going to be this person right here, or somebody in your family, or somebody you know. So our work is really about trying to get in early and trying to give defenders on the ground, because this is where that connection does happen, the tools that they need to fight these kind of charges, and to tell judges, to tell prosecutors that carceral responses are not ever going to be the adequate response for a healthcare question.
Thank you. And let me just remind the audience that the chat will contain numerous resources for good information. either from one of the organizations represented today here or other organizations, credible sources of factual information to help you stay up to speed with what's going on. But speaking of up to speed, there's kind of an alphabet soup of federal organizations that have claimed a stake, shall we say, in this set of issues. The Centers for Disease Control, the Centers for Medicaid and Medicare Services, the Food and Drug Administration. I'm going to start with the Food and Drug Administration because many people may not be aware, or maybe they are, but don't understand that a lot of abortions occur through medication. So the Food and Drug Administration, tell us, Dr. Parrott, tell us, Dr. Tosh, what role does the Food and Drug Administration have with all of this?
So, that makes it, this current administration makes it more difficult to ask, which should be a very simple question.
Yeah.
The role of the Food and Drug Administration is to take the science, the evidence-based, and to make decisions about the safety profile of medications based on medical evidence and scientific evidence. What we've seen under this administration is a co-optation of that power, and instead we're seeing drugs that are safe, like mifepristone, for medication abortion, being targeted and restricted through lots of mechanisms and ultimately criminalized and restricted in ways as if they were dangerous medication. So, for example, there's a large sort of variation in terms of the way we control medications, right? Something like ibuprofen or Tylenol that you can get over the counter is going to be one of the least restricted things. And then something like a narcotic, right? Like oxycodone or fentanyl is something that's going to be highly restricted. That is based on addictive potential and potential for overdose. What we're seeing is mifepristone, one of the medications used in medication abortion, is being restricted as if it had a high addictive potential or it had a high risk of overdose. And neither of those things are true. In fact, mifepristone has a more favorable safety profile than Tylenol, which you can get without a prescription over the counter. So we have seen politics really being put in place to an ideology to supplant medical evidence under this new iteration of the FDA.
Thank you. And Jenna, how does Planned Parenthood think about these issues and interact with the FDA? Because I know they do.
Planned Parenthood is one of the largest providers of abortion across the country, and medication abortion has been growing as a share of all abortions since its inception. The FDA has not only, as Dr. Parrott said, stated very clearly that mifepristone is safe, but there have been several expansions in access to mifepristone over the past 20 or so years in terms of, gestational limit and telemedicine provision of mifepristone. And so all of these expansions in access are very meaningful and have led to a growth in availability. At my affiliate, I actually don't know what probably Dr. Parrott does, the most recent data on mifepristone or medication abortion as a percentage of all abortions. At my affiliate, it's 73%. The vast majority of patients who come to Planned Parenthood to access abortion end up choosing medication abortion. And that's for a few reasons, but one of them is access. States like California have said that mifepristone is so safe, and it is so safe to be dispensed by advanced practice clinicians, right? It doesn't necessarily have to be a physician. And that is now one of the issues that is at odds with this FDA, because ultimately limiting prescriptions to doctors only has the impact of dramatically limiting access to this very safe and effective early pregnancy abortion, abortifacient medicine. And so, I think, how we would operationalize all of these restrictions, essentially the answer is there would be no practical way to operationalize without limiting access. And of course, that's the point.
Yeah, that is the point. So that you take it away from something that you're restricting to a state, or a county or a specific entity into much, much broader access. And I think that that's something that's needs to be addressed. What about the Centers for Medicaid and Medicare Services? People maybe, I'm not sure who should address this question. Anybody can, but I think somebody alluded to the HR1 impact. Please tell us, how does that directly impact reproductive healthcare writ large? Because it's coming up now, the government could shut down over partly just this issue. Anybody?
I mean, I'm happy to jump in, or
Go for
Dr.
it.
Parrott. Look, I think largely what HR1 does is it rolls back many of the expansions to Medicaid over the past decade. HR1 will make healthcare less affordable for communities who need access to Medicaid. It does that in a variety of different ways. One of them is work requirement piece. It really rolls back major expansions in the ACA marketplace, in Medicaid. It also limits the ability of states to increase provider rates for Medicaid, which is a very important thing that states can do in response to provider shortages on the ground, which are often due to lack of appropriate reimbursement. And so many of the impacts of HR1 have been staggered and won't be felt until 2027, 2028. Really, with one of the major exceptions to that being the Planned Parenthood defund, which was written to go into effect immediately and to be in effect for a period of 1 year. But we are looking at just a major divestment from public health. And as we've already talked about, that is coinciding with a real attack on science-based medicine. And so it will be up to Center for Medicaid and Medicare Services to implement some of these draconian provisions in HR1. And the truth is, we don't know exactly what that will look like. It's also up to CMS to implement a number of these executive orders that are coming out related to healthcare access, and they will have some discretion in how that looks, which is concerning, right? Because we really are, I think everyone here knows, in a very unprecedented moment, because these agencies are not behaving in a way that is predictable. And I think, as we've discussed, really deviating from what has been understood to be in the best interest of public health and public safety and communities for the past 8 months. So I think, all of these agencies have a lot of power, and they will have discretion. And, I think that's just another area that we're going to have to really stay focused on, and not only stay focused on trying to influence what they might do, but on mitigating the impact at the local and state level to the extent that it's possible.
I'm actually going to back up a little bit, if that's okay, just to explain what the Center for Medicaid and Medicare and Medicaid Services actually does. Sometimes it's called CMS. So if you heard Jenna use that acronym, then that's what CMS is, the Center for Medicare and Medicaid Services. And their role is to actually oversee. It's a federal agency, right? And it's to oversee and to administer the Medicare and the Medicaid programs. Medicare is what we think about the insurance program for seniors. Medicaid is the program that we talk about for folks who have disabilities or who are living on low incomes, for example. Now, this provides coverage for more than 100 million people in this country. But this CMS also manages the CHIP program, and CHIP stands for the Children's Health Insurance Program. It also establishes health and safety guidelines for providers. It oversees the administration of the HIPAA process. So that's the Health Insurance Portability and Accountability Act. That's what HIPAA stands for. That's the privacy protection that you get to say that what happens in your doctor's office is private. And then the last thing that I'll just help folks understand the about CMS is that it also manages the health insurance marketplace. The reason why this is important is because the person who is leading this organization then has been given the power to make decisions about access to care for hundreds of millions of people in this country. Medicare, Medicaid, CHIP, the health insurance exchange, all of those are under the purview of CMS.
Yeah. Yeah, you're
And if
right.
I can
Those are
just jump in.
huge, very important. Yeah. Karen, did you want to say something?
Yeah, and just to jump in again
Yeah.
about how all of this stuff begins to spill over into the legal arena. This past year in the last legislative session, there were 10 different states who tried to introduce bills that would equate abortion with homicide. Okay, so they would make abortion a felony, which would, in fact, in many of those states, make them a death eligible offense. Okay, so what that means is that if you provided information about an abortion, you could potentially be an accessory to a crime. And it also means that these states are kind of changing the definition of legal contraceptive and adding a new definition of human embryo so that there would be new restrictions on currently available methods of birth control and family planning, right? So you're making abortion a felony equivalent to the homicide of a person. You are making abortion have a possible 30-year sentence if you, again, aid in it or take part in it. It would change the legal definition of contraceptive, and it would also open the doors to restrictions on IVF. Obviously, anyone who possesses drugs or substance uses for abortion would also face some of these issues, right? And so what this means is that we're also getting to this point where if people aren't getting the care that they need under Medicaid, if this change in with the big beautiful bill is making it harder for people to get the care that they need, and they begin to have more and more undesirable pregnancy outcomes, those outcomes are going to become automatically suspect, and people are going to be charged or accused of ending their pregnancies, whether or not that's actually based in the science. Given the examples that I was saying earlier, there's a very weird, slippery line here that we're about to find out how it's going to, what the import of those things are going to be. We know that maternal and fetal outcomes are terrible already in several states. And so we are very worried about where this might lead and how the kind of oversight and surveillance by providers might feed into this as well. So it's all a very tangled web.
Yeah, you're right, Karen. And I'm going to segue into a couple of questions that have been posed specifically for you by the audience. And so thank you, audience members. We are continuing to get your questions, and I would like to address them. But somebody is interested in a deeper dive on the implications of fetal personhood and how this opens the door for taking the rights away from everybody. So maybe just give us a little more substance on that, please.
Yeah, so fetal personhood is the idea that a fetus has exactly the same rights as you and I, right? So that means that a fetus has constitutional rights that they are entitled to, from due process to to everything. And I don't think that's been thought out particularly well, because we're having this tension between folks wanting to end birthright citizenship, right? And at the same time saying that all fetuses have the rights of everyone else. So that's going to be something that we're going to have to work out. But aside from the things that I've mentioned before, that any behavior that someone does not agree with might lead to charges. The other, I think, big issue, and again, this goes to something that Dr. Tosh said earlier, is that say there's an executive order that says, I now declare that all fetuses are entitled to 14th Amendment rights, that they are persons under the law, or if the Supreme Court has an opinion that decides that, what that means is that this is no longer a question for the states. It'll mean that all abortions are going to be illegal across the United States, whether you live in a blue state or a red state. So I think that sadly, the idea of fetal personhood feels very wonky. It feels very legal. It feels very in the weeds. When in truth, all it is saying is that fetuses have the same rights. And so if we really look at that, if we look at where that leads and what it lays track for, I think people get it. And we know this. We've actually done polling with the National Women's Law Center on this very issue. And when people don't hear the kind of like legal words and just hear what fetal personhood is, the vast majority are like, absolutely not. We don't agree with that. We don't think that's correct. And so I think we need to do a little bit more consciousness raising about that. We need to get that out there about the kind of deep impact of this really kind of fringe and radical ideology. But we also need to be very aware of how much it's already baked in to the pudding, that people are already using it all across the state or across the nation in ways that I think people feel okay with, because it might be about like someone being assaulted, right, and losing a baby. And everyone's like, oh, that's great in that situation. But if there's anything you hear from me that you take away today, it's about this creep. Nothing ever stays still, because it's not actually about the fetus. Otherwise, we wouldn't be talking about these Medicare cuts that would actually be helping fetal health. It's not about the fetus. It's about surveying women. It's about keeping them out of the public square. And it's about criminalizing them for behaviors that people do not like. And that is a patriarchal question. That's a sexism question. And that's not, again, that is not a healthcare question. So we all have to be very loud and forceful about pushing back around fetal personhood principles.
Yeah. Someone actually asks if women are going to be arrested for taking Tylenol.
I mean, they might be, right?
Yeah.
I think I can't say we don't know what's going to happen. And I hope that there are many more doctors like Dr. Parrott and Dr. Tosh who are actually educating their peers on a lot of these questions. But the fact is, I think there are a lot of things tied up in this, right? Because the line that people have said over and over is that mifepristone is even safer than Tylenol. But if you make Tylenol unsafe, then you are by default making mifepristone. You're questioning both its efficacy and its safety, right? So there are a couple of things going on at the same time, but I think this is kind of the end game, is to make Tylenol something dangerous. And the other thing that we can't drop is, part of that announcement was the president saying, well, women just push through, suffer through, you'll be fine. You'll be fine. And that's another part of this. There's this idea that folks should suffer, that you should give up your health, you should give up your life, if for what other people think you should be doing during your pregnancy. And that, I think, will also extend to this attempt to make Tylenol seem like a harmful thing.
Yeah. So I know all three of your organizations spend a lot of time and effort trying to educate the public, and in some instances to educate other professionals. Let's talk about the kind of the pipeline to getting to be one of the professionals. How do you educate law students? How do you educate medical students, midwives and nurses? So I'll ask each of you to address that, and maybe I'll start with Jenna, please.
Sure. Yeah. I mean, I think this is a really good question, because one of the things that has happened since we lost Roe is it has become increasingly difficult for, in particular, OBGYN residents, but all medical residents, to get appropriate training on not only abortion care, but on managing a wide range of pregnancy complications. And that in and of itself presents some real risks. And I know Dr. Parrott will have a lot of thoughts just about what is important in this moment. But I think, speaking from Planned Parenthood, we absolutely see provider training as an important part of our mission. It's about the future, and ensuring that we're not only delivering care today, but that we are contributing to excellence in medicine and in reproductive health really matters to us. And so we have partnerships, local partnerships with, nurse midwives, nurse practitioner, advanced any advanced practice clinician programs. And we also have a partnership actually with a local Catholic OBGYN residency program where we ensure that OBGYNs in this program receive training on abortion care, on IUDs, and long-acting reversible contraception, and things that they may not be doing routinely much of, or if at all, where they're training, and all of that really matters. And some of the most robust institutions and training programs in the country existed in places where abortion is now not legal.
Yeah.
And that is going to have an upstream impact on the comfort level of providers across the country to see patients dealing with pregnancy loss, pregnancy complications, or patients in need of abortion care. And so, I think that this is, I know a lot of smart people are thinking about this, but I do think it's important to remember that medical training happens in medical centers, right? It happens where care is being delivered. And when care is altered by the law, that also means that providers are not going to be receiving the type of training that they once were.
Mm-hmm. Jamila.
So yes, I agree 1,000% with that. And so one of the things that we're doing is exactly what Jenna talked about. We're making sure that we're engaging in outreach to trainees, trying to get folks early, right, in their medical education and training. The reality is that a lot of people come to medicine, most, if not all, come really deeply grounded in social justice values. And there's a transformation that happens during medical education, right? A conformity that is required to survive the system. And as a result, we see people that come out transformed and not always for the better once they're done with their medical education. And I think that happens probably in the professionalization of a lot of things, right? Not unique to medicine necessarily. So we work with doctors through our Leadership Training Academy program, for example, to do advocacy and policy work, really deeply grounded in reproductive health rights and justice. We partner with organizations like Medical Students for Choice, that is really engaging with medical students on a really deep level, as well as nursing students for sexual and reproductive health, and lots of other particularly Black-led reproductive justice organizations that are doing grassroots work, in particular in the South. I think it's important to understand, and this was a question that was asked in the chat, what is the implication of all of this on medical education and training? And Jenna talked a little bit to that. The research is showing that medical students are much more reticent to apply to OBGYN programs in states that have restrictions. The numbers haven't shown a decrease as of yet, but there is some concern, right? People are fearful. The reason why this is important is because 70% of residents remain in the community where they did their training. And so what that means is that there is a significant loss, there's an attrition of providers in communities that are already struggling for resources. And when we look at where that's happening, it's happening in the South and it's happening in the Midwest. And in particular in states where most folks are living in rural communities, most Black folks live. And so we're going to continue to see worsening reproductive health outcomes from communities that are already experiencing poor health outcomes overall.
Karen, what about the legal profession and future attorneys?
I think luckily for us, I think that folks have been doing this work for a very, 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 very long time. Dobbs is incredibly recent. Pregnancy criminalization has been happening much longer than the fall of Dobbs and, quite frankly, the issuance of Roe. So this has been the work and the life's calling for, I think, a lot of lawyers for a very long time, and that is not stopping. We never have any issues with fellows and interns applying to work with us. I think that in a lot of ways, this feels like a very proactive space to be in. I think there's something that is reassuring about being able to act positively in this space. I think it's actually quite hopeful, and working with younger lawyers on this has been a great pleasure and balm for the soul in this moment.
Well, you're all certainly great role models for careers that lots of fields could benefit from having a young professional or just individual looking for fulfilling work. So I'm going to take some more questions from the audience. This one, I think, or these are it's kind of a couple of related questions about related to the fetal personhood part, but also related to contraception and ethics. People have been talking about these things for years, but how do doctors define fetus compared to the way the current administration defines fetus? And yeah, so it's a legal question. It's also a medical question. So I'm going to ask Jamila and Karen to please address that.
So there is no point of viability. That's not a medical thing at all. And viability. So viability in and of itself is the chance that the fetus would survive if delivered. And Karen mentioned this, right? In this moment, viability is a window, right? It is a long window, a picture window, right? Because it is influenced by so many things. It's influenced by age, by race, by your location. If you're in a rural hospital, for example, and you don't have the same resources that may be in an urban hospital, if you're at a place that doesn't have a level 3 neonatal intensive care unit, then the threshold of viability is going to be different as opposed to if you do, right? And so viability isn't something that you can point to in terms of a number of weeks or days of pregnancy, but it's taking all things into account. What is the likelihood of survival? Now, that doesn't even take into account what we call intact survival. So survival without significant physical or other sort of harms or delays that may occur with extreme prematurity, for example. And so there isn't, I could not give you a number. When I'm asked, I can't say that this is the age of viability or this is the number of weeks. This is, Karen, I think we'll talk about in just a few minutes, once I be quiet, is something that was created by a legal framework and not at all from a medical perspective.
Exactly. And you know, in the run up to Roe, there's other cases that kind of dealt with the same question around abortion rights. And in those cases, you see the judges basically saying, well, if we give them this right, we have to do something to just limit it. We have to. They can't just have this unlimited right. And so they came up with a viability framework. And listen, people are going to have their own interactions with their own pregnancies, right? And for some people, life does begin at conception, and that's fine. Everyone should have their own belief about that. What we shouldn't be doing, however, is legislating on people's beliefs, whether they're religious or personal, but on what is best, scientifically speaking and medically speaking. And we wrote a viability report with our really good friends at Patient Forward, and everyone should take a second to look at the work of patiency. Oh my gosh, I'm putting us together because we worked so tightly together. But Patient Forward does really fabulous work on later term abortion questions. And why this is important is because there are a lot of reasons about why people need that care later on in their pregnancies. And that should be a decision left to those couples and not left to judges and not left to people who just are coming at it through a place of judgment. It doesn't help anyone. And again, it is not rooted or based in any kind of medical truth or fact. And so we shouldn't be having judges creating random guidelines that are influencing the care that people need.
Yeah. So this is one I've never heard before, but someone has asked whether criminalization of pregnancy is affecting attitudes towards wanting to become pregnant. Are people choosing not to? Have you ever seen this? People are choosing not to have children because of some of these criminalization incidences and fear that miscarriage could land them in jail.
I don't think that people are not choosing to become pregnant because of criminalization. I think they're choosing to not become pregnant because they can't afford it, they don't have housing, all of the many other reasons that make it almost impossible to parent in this moment. And I don't think that people necessarily know about it. I think, one thing that we are seeing is that people are getting a little bit clearer around things like arresting people for abusing a corpse when they are throwing out fetal remains after having a miscarriage. I think people are really getting resistant to this kind of state sponsored ignorance where people are kind of normalizing terrible responses, but they're also terribilizing normal responses because most, like 20% of pregnancies end in miscarriage, right? It is a very normal thing in the world. It's not something that is shocking. It happens quite frequently. And when people see folks getting, but there's a recent case in Kentucky where the headline was, woman wraps baby in garbage bag and puts in closet. And it's like, well, was that a miscarriage? And did anybody say this is how you dispose of fetal remains? No one does that because that is not a conversation people have. And I think when people see that kind of thing, when they see those kinds of attacks on people who are in the midst of a loss, I think that hits really hard and very realistically because everybody, I think, knows somebody who has been through that.
Yeah, I think I'll add, I agree 1,000% with what Karen is saying. And with one caveat, I don't know that people are choosing not to become pregnant, but certainly people are choosing not to stay pregnant for all of those reasons. Because the ability to choose to become pregnant or not is deeply grounded in the amount of privilege and resources you have in the first place, right? It shapes the meaning of that choice. So access to birth control, access to IVF, access to community grounded and culturally responsive pregnancy, prenatal, and postpartum care. All of those things shape it. I have definitely seen a number of folks choosing not to become or remain pregnant, Black women in particular, because of fears around maternal mortality risk and the inequitable outcomes for Black women. I have seen that clearly time and time again in my work and in my practice. Pregnancy criminalization is a little bit less well known. And that is simply because the people who are often targeted are not the folks yet, are not yet the folks that have higher social capital. We're talking about Black and brown folks, immigrants, poor people, young people, people living in rural communities. And so the likelihood that someone who is resourced with power and privilege is going to be targeted, it will come. Make no mistake, but we aren't seeing that yet. And so folks are feeling like it doesn't touch them. It's not their issue quite yet.
I'm going to ask both Jenna and Karen to respond to a question of what is going on. No, how can I put this? Not what is going on, but how have your organizations had to face, or have you, any of the recent threats from ICE arrests? Do you see this coming? Jenna, you first, and then Karen.
Look, I mean, I think for anyone who is listening, who is not in a community that is actively being targeted by this aggressive immigration enforcement, I can't underscore how deeply shaken our communities are here on the Central Coast of California. My affiliate serves a large immigrant population. There are a lot of immigrant farm workers in our communities, people who are already very vulnerable. I mean, we are talking about folks who do seasonal labor in our communities, many of whom don't speak English or Spanish, but instead speak indigenous languages from communities in Mexico. And the sort of scale of the ICE operations and the militarization of ICE operations in our communities has been devastating and shocking. And we have seen this administration already roll back protections for sensitive spaces, including houses of worship and healthcare facilities. I do think that this is one of those areas where, at least at this point, we are seeing a lot of institutional resistance in my area to collaborating with ICE. We have signage on all of our facilities, making it clear that folks are not permitted entrance without a warrant. We have seen a few attempts on federally qualified health systems, federally qualified health centers, as well as hospitals. I'm not aware of any in my communities where folks have been granted entrance, but this is a constant conversation. And, I think one of the other things for folks to know is that not only is the threat physical interruption of healthcare services, but, via the Center for Medicare and Medicaid Services, as we were talking about earlier, they have already provided data to Border Patrol about folks on Medicaid rolls, and that is another huge concern for our communities, is just the weaponization of healthcare information in this very specific way, which again just causes fear. And so, the primary way that we have seen the impact is that folks are scared to get access to care. And we have seen that very clearly in the days and weeks following really aggressive immigration enforcement in Ventura County, in Santa Barbara County, in Santa Maria. It is there, you can see a very clear correlation between those operations and people coming to care. And so we're trying to do as much patient reassurance as we can, really making sure that our communities know that at Planned Parenthood, we don't ask immigration status. Patients can continue to come and access care. And we're just doing everything we can to make sure that our staff is trained and that we are as vigilant as we possibly can, because, people should feel safe accessing healthcare. And they're not gonna take care of themselves. Folks are not gonna take care of themselves if they don't feel safe coming in for care.
Karen, would you like to weigh in?
Well, first and foremost, I would like you, if you're watching and anyone who needs help, to call our intake line and know that if we cannot help you, we can at least get folks to you who might be able to help. Immigration is a very different kind of practice. And so we want to make sure that you have people who are well versed in those issues and that we can support them in potentially litigating your case. But that being said, we also are very clear about what healthcare is like and the treatment of pregnant folks in prison is like. We know what that is. We recently settled a case in Alabama where a woman was forced to give birth for 14 hours to labor on a jail room floor by herself in the shower while people watched and took pictures, right? So we know what happens in prisons. We know what happens in jails to pregnant people. And we also know how much worse those circumstances are in these ICE facilities. I think Dr. Parrott put a resource in the chat that I would ask everyone to look at, but we are in very serious and scary times. And I just hope that the resources that we do have can get to the people who need them the most.
Well, I think this is an outstanding panel. We could go on, but we're just about out of time. I'm going to say quickly, in maybe 1 minute or less, I'm going to beg the timekeepers to give me a break here. But how, some of it can feel overwhelming. So how do we address that sense of overwhelm? Each of you, just 1 minute before we get to calls to action. What do you do to prevent feeling overwhelmed by all of this?
I can start. I think the first thing that I would offer is the feeling of chaos and overwhelm is the intent. That's the point of this. It's distraction, it's overload, it is a tool to make you feel like it is impossible to fight back. So one of the things that I do is remember that that is part of the plan, right? That this is by design. And that's important for me because otherwise it isn't possible. The other thing that I do is rest. Recognize that there are a lot of people that are in this fight. It doesn't absolve me of my responsibility, but it's okay to tap out sometime and let somebody else tap in. And in order to do that, it means I have to be in community with people that I deeply trust. So I know that they would be representing my interests and I theirs when I'm not at the table or they're not at the table. So that requires to build relationships and relationships across movements. So even though we're talking about the criminalization of pregnancy, the relationships that we build to fight this are with folks that are fighting immigration detention issues, folks that are talking about violence in prisons and carceral systems more broadly, folks who are talking about family policing in general, not necessarily just what happens during pregnancy, right? So really moving across movements and building those bridges so that when you need to take a breath, somebody else can lift their voice up. And we know that we're all fighting for the same thing.
Yeah, I would just say that you don't need to be William Lloyd Garrison. You don't need to be Dolores Huerta. You don't need to be Martin Luther King to get to do something that can push the needle. I think that another part of the overwhelm is just being like, I'm one person. What could I possibly do?
Mhm.
And it's like you, as one person, can do a lot. Sometimes that is bringing cookies to your local Planned Parenthood and just being like, thank you for what you're doing, because that is giving someone else a moment of rest and a moment of recognition. And that kind of soul resting, that interconnectedness, that care is deeply, deeply important to being able to stay present and to be able to do the work that we all, I think, need to do to meet this moment. And then the other thing is, I think, and I'm just going to say this a lot. I've been saying it a lot recently, but I think people think that hope is like Tinkerbell, and you open a bottle and hope flies out and she's dainty and all that stuff. Hope has a bloody nose. Hope has ripped clothes on. Hope is dirty and scratched up and beat up because she's getting knocked down and she keeps getting up and staying in the fight. And so I think we have to recognize that hope is a practice, and it is a practice that is difficult, and it is a practice that is hard. But every time we allow ourselves to do that, she comes back. And so I think we have to work on building hope in ourselves and hope in other people.
That's great. That reminds me of the Maya Angelou poem, Still I Rise. Okay, Jenna, how do you avoid the sense of overwhelm?
Dr. Parrott and Karen answered that question perfectly. So, I'll just sort of thumbs up it and remember, that this is a marathon and not a sprint, right? And so we are not going to solve these problems overnight. What we can do is we can be in community. We can find the folks who are most impacted really at the crosshairs in this moment, and we can support the organizations and the activists on the ground that are doing the work to try to ensure that people have access and to ensure that we can restore some justice in our communities. And so, yeah, I mean, I think that this is a really long-term fight. And I think one thing you can always do is pick up the phone and call your member of Congress. It's always a good idea to just really make sure that you know who your member of Congress is, you know who your state and local officials are, that you have those numbers saved in your phone, and that you are being vocal, right? Because we have to make sure that our lawmakers continue to hear the urgency long term.
That's great. And in fact, that is this is our closing moment when we do the calls to action. And Jenna, you just took mine, because mine was keeping your lawmakers accountable. Know who they are. Pick up the phone. You don't necessarily have to talk to them. Usually you get a voicemail message anyway. Just say, I live in your district and this is what I think. They'll get back to you. Okay, that's my call to action. Call to action is your chance to emphasize things. Marion, do you want to go next?
I would love to go next, and I'm going to pick up with what Karen said about hope, and I would encourage you to have hope and joy in the hope, because it will bring us forward. And please share this forum, the videos of this forum. There's going to be a short one and a long one. Share them with everyone you know, because the information that we have received tonight will help us all take action. And then I have a friend who helps people get into her Planned Parenthood in Brookline, Massachusetts, every week, or a couple times a week. And you can volunteer to do things like that. You can volunteer to help pregnancy justice. You could think about what you can do. And those of you who can afford it, please give money to all these organizations so that they can all continue. So those are my calls to action for Class Act. And I am just extraordinarily grateful that we have had all this humanity in one place, and hope. So.
Dr. Parrott, you want to go next?
I do. I would be remiss as a DC native not to say that this call your congressman does not apply to us. So when you're thinking about what representation means, when you're thinking about the fall of democracy, recognize that those of us who are living in occupied territories like DC, like Puerto Rico, like Guam, do not have representation at this time. In terms of DC, I'm not going to speak for Puerto Rico or Guam. DC statehood is what we're calling for. So in addition to fighting for what's happening in your own community, and this is truly my call to action, understand that what's happening here in the district today, under federal occupation, the militarization of our streets, our police forces will be coming to a city near you soon. So understand, again, my call is to realize that our liberation is bound. And so we cannot fight this one by one by one. We can't focus only on abortion, only on pregnancy criminalization, only on immigration, but understand that these things are deeply interconnected. And then as an abortion provider, I would say, please donate to abortion funds in your communities and around the country. These are folks that are providing not just helping folks actually pay for the abortion, but true wraparound services and material needs for folks.
Karen.
I have actually three, so I'll try to say them very quickly. The first is please sign up for our newsletter. You can do this again by just going to our homepage, pregnancyjusticeus.org. And if you live in South Carolina, or if you know someone who lives in South Carolina, please tell them to call their lawmakers and tell them to vote no on Senate Bill 323. That's that bill that would make abortion a homicide in that state. There, again, it is a spread. We've seen 10 different states introduce these kinds of bills. We have this one in South Carolina that's coming up for a vote on October 1st. It's very important that if you know anyone there, that they make their voices heard to their legislator. And also the last thing, we're going to have a webinar on the 30th of September where we will be presenting our new data about what we've seen in criminalization trends in the second year post-Dobbs. So it would be great if you could join us to hear a little bit more about our research, what we're finding that's going on in the country, and how you can help.
Jana, last but not least.
Yeah, I had already mentioned I'm the CEO of Planned Parenthood California Central Coast. There are 48 affiliates across the country. And so I would really just encourage folks to connect with your local affiliate, find out the sort of support they need on the ground. Make sure that you're on their newsletter, find out what their local calls to action are. We really are experiencing very different needs across the country. And as I said at the start, for the past 2 weeks, Planned Parenthood has been seeing patients and not being reimbursed through Medicaid. And so the needs are big. And I just encourage folks to find out what that need looks like on the ground in your community. Thanks.
And don't forget, there is a benefit for Justice Aid is giving a benefit for pregnancy justice. Please look at the chat to get those details. And with that, thank you all for your attention. Thank you to our wonderful panel. You've been just amazing to speak with.
And thank you, Vivian, for leading such an extraordinary conversation with 3 other spectacular women. So it's a great pleasure to have been able to host this with the 4 of you this evening. And I want to thank you so much. I also want to thank the Justice Aid and Class Act members who worked to put this together. And those are Therese Steiner and Steve Milliken, Valerie Jowett, and Kim Coaxum, and also the Class Act production team, John Noren, Diana Labanchu, Jackie Swearingen, Sarah Ulrich, Richard Jackmaw, Katie Marinello, Kate Freed, and our videographer, Rick Brotman. And finally, I want to thank all of you who have attended this evening.